Today, we're going deep into the absolute marvel of electrical engineering sitting right inside your chest. Because, when you picture the human heart, it is almost impossible not to just visualize a mechanical pump.
Right, just a dumb muscle-squeezing blood, lub-dub, lub-dub.
Exactly. But if you actually zoom in past the muscle tissue, you realize the heart isn't just a pump at all. It runs on a beautifully complex, highly sensitive electrical grid.
It's entirely self-sufficient in that way, too. Like, unlike your skeletal muscles, which just kind of sit there passively waiting for your brain to send a nerve impulse before they decide to move, the heart is its own autonomous power plant.
Oh.
Yeah, it possesses this property called automaticity. So it generates the spark all by itself, relying on these specialized cells that intrinsically fire off their own rhythmic electrical spikes, their own action potentials, essentially.
And without any outside signals telling them to do it.
None at all. It just happens.
Which is incredible. But like any complex electrical grid, sometimes the wiring goes haywire, sometimes you get a short circuit. And that's exactly what we're figuring out today. We are unpacking the intense, high-stakes world of antiarrhythmics based on our pharmacology source text.
It's a fascinating area of medicine.
It really is. We're going to explore how doctors use some seriously heavy-duty chemical engineering to patch the heart's electrical grid when it breaks down. So whether you're a medical student cramming for boards or, you're just someone fascinated by the extremes of modern medicine, you're in the right place.
Absolutely.
We're going to get you those essential aha moments about how these drugs actually work, the bizarre side effects they cause, and the massive, almost unbelievable paradox at the center of treating irregular heartbeats.
But to understand how to fix a broken rhythm, we really first have to understand the specific pathway of a normal one.
Right.
It's an exact sequence, and it all starts at a cluster of cells called the sinoatrial node, or the SA node. That is your heart's natural pacemaker.
Right, and it gets to be the pacemaker simply because it's the fastest, right? Like, it has the highest rate of spontaneous depolarization.
Exactly.
I always picture it like a room full of people all slowly raising their hands, but the SA node is that one eager kid in the front row who always throws their hand up first.
That's a great way to look at it. And once that eager kid, the SA node, fires, the impulse travels down a highly coordinated pathway.
Okay.
It moves to the atrioventricular node, the AV node,
Yeah.
then down to the bundle of His, and finally spreads out through the Purkinje system to make those massive lower ventricles squeeze.
And it's that precise coordination that ensures blood is pumped effectively.
Right. But when that sequence dysfunctions, that's when you get an arrhythmia. And these present as a pretty complex family of disorders. Well, the rhythm might become dangerously slow, which is bradycardia, or it might race too fast, known as tachycardia. Or, it might become totally chaotic and irregular, like in atrial fibrillation, where the upper chambers of the heart are essentially just quivering instead of pumping.
So the big question is, why does the grid fail in the first place? Based on the text, it seems to boil down to two main culprits.
It does, yeah.
The first is abnormal automaticity. Because here's the thing, the SA node isn't the only part of the heart capable of generating a spark.
Not at all.
You have other latent pacemaker cells scattered around. Normally, the SA node fires so fast it just overrides them. They never get a chance to take the lead.
Exactly. But if those latent cells get damaged, say the patient has suffered from ischemia and the tissue is starved of oxygen, or maybe there's a severe potassium imbalance in the blood, the resting state of those cells changes.
Okay, so what happens then?
Their electrical threshold drops. They reach their firing point way too early. So suddenly you have these rogue, damaged cells competing with your normal SA node, throwing off conflicting electrical sparks.
Wow, so it's literally an electrical mutiny.
That's exactly what it is.
But as chaotic as that sounds, the second culprit is actually the most common cause of arrhythmias, right? Abnormal conduction, specifically something called re-entry.
Re-entry, yes. This is a crucial concept.
I was trying to visualize how re-entry actually works on a physical level. Like, imagine the normal heart is like a perfectly synchronized orchestra, and everyone is following the conductor, which is the SA node.
Okay, I like this.
The music flows perfectly from the strings to the brass. But a re-entry loop happens when there's an injury to the heart muscle. It creates what's called a unidirectional block. So it's like one section of the orchestra, let's say the violins, encounters a roadblock in their sheet music.
Right, an area of damaged, scarred tissue literally prevents the electrical signal from moving forward down that specific anatomical path.
Exactly. So the signal is forced to travel down a normal, unblocked pathway instead, but then it loops backward. It travels retrograde, sneaking up the blocked path from the other side because the tissue only blocks the signal in one direction.
Yes.
So now those violins are stuck on a repeating infinite loop. They're playing the same chaotic measure over and over, completely ignoring the conductor and throwing the entire symphony into absolute chaos.
That is a highly accurate way to look at it, honestly. The electrical impulse literally re-enters the same tissue it just left, creating a permanent short-circuit pathway.
So it just spins.
Yeah, it just spins in a continuous loop of re-excitation, causing premature contractions or sustained dangerous tachycardias.
Yeah.
And all of the antiarrhythmic drugs we're looking at exist to solve this specific problem.
They're designed to either suppress the rogue mutiny cells or break that spinning reentry loop.
Exactly.
Which sounds totally logical until you run headfirst into what might be the most terrifying reality in all of pharmacology.
Yeah.
The proarrhythmic paradox.
Yes, the paradox.
We are talking about drugs designed to fix irregular heart rhythms. Yet many of these very same antiarrhythmic agents have dangerous proarrhythmic actions, meaning they cause arrhythmias.
Yes, they do.
Wait, so the cure is also the poison? To fix the heart's rhythm, a doctor prescribes a drug that carries a very real risk of ruining the rhythm even more. I mean, how is that an acceptable risk for any medical professional to take?
It's a huge question, and it raises a profound point about the ethics of emergency intervention. It seems completely counterintuitive, even reckless on the surface.
Right.
But if we connect this to the bigger clinical picture, it is strictly about the lesser of two evils. When a patient is in sustained, life-threatening ventricular tachycardia, their heart is beating so fast and so erratically that it isn't actually pumping blood.
It's just sort of vibrating.
Exactly. They will die in a matter of minutes. The doctor has to intervene to stop that immediate lethal rhythm, even if the chemical tool they use carries a 5 or 10% risk of triggering a different irregular beat down the line.
Oh, wow. Okay.
It's a calculated high-stakes gamble based entirely on the severity of the crisis right in front of them.
Okay, so high stakes, high risks. A literal life or death tightrope walk. So let's look at the first group of tools they use to walk that tightrope. Class I drugs, which are sodium channel blockers.
To understand Class I, we need to dive down to the cellular level for a second.
Let's do it.
Think about the very beginning of that electrical spark we've been talking about. During an action potential, the sequence that causes the muscle to actually contract, there is an initial explosive influx of sodium ions rushing into the cell. This rapid spike is called phase 0.
It's the match that lights the fire.
Yes, and Class I drugs block those tiny sodium channels on the cell membrane. By decreasing the speed that sodium can rush into the cell, they slow down that initial explosive spike.
But the absolute most ingenious part of this mechanism is a property known as use dependence, right? Or state dependence.
Yes, this is a brilliant quirk of molecular engineering.
Basically, these drugs don't just blindly block every single sodium channel in the heart. Because, I mean, if they did, the heart would just stop.
It would, yeah.
Instead, they bind much more rapidly to channels that are actively opening and closing. So if a part of the heart is beating at a normal, healthy, low frequency, the drug largely ignores it, it just floats on by.
Right.
But if a section of tissue is discharging at a wildly abnormal high frequency like during a tachycardia, the drug swoops in and blocks those specific channels heavily. I read it and thought, it's like a highly intelligent bouncer at a nightclub.
Oh, I like that.
The bouncer completely ignores the patrons who are just dancing at a normal, steady pace. But the second someone starts wildly spinning out of control, knocking into tables and causing a scene, the bouncer steps in, targets them specifically, and kicks them out.
That's a perfect visualization.
Right.
The drug is essentially seeking out the exact cells that are causing the problem because their very hyperactivity is what exposes them to the blockade in the first place.
That is so smart.
It is. Now, within this Class I family, you have subclasses based on how strongly they bind. Class IB is a major one, with lidocaine being the prototype.
Lidocaine.
Yeah.
Which, most people know as the shot the dentist gives you to numb your gums.
Right. But in cardiology, it's the drug of choice for the emergency treatment of ventricular arrhythmias, particularly the ones that pop up right after someone has a myocardial infarction, a heart attack.
Okay, so how does it work?
It specifically shortens the repolarization phase. Phase 3, meaning it decreases the overall duration of the action potential. But it has a very specific administration requirement. You cannot take lidocaine as an oral pill.
Right, because of the liver.
Exactly.
The liver acts like this highly aggressive border patrol for the digestive system. Everything you swallow and absorb through your gut goes straight to the liver through the portal vein before it reaches the rest of the body.
Yep, the first pass effect.
And the liver enzymes recognize oral lidocaine immediately, completely metabolizing and destroying it in what's known as first-pass transformation. If you swallowed a lidocaine pill, basically 0% of the active drug would ever reach your heart.
Precisely. So it has to bypass the liver via an IV.
Makes sense.
Now, on the other end of the spectrum, you have class IC drugs, like flecainide. These don't shorten the action potential. They markedly slow down that initial phase 0 sodium rush.
Okay.
They're incredibly potent at suppressing premature ventricular contractions. But going back to your shock over the proarrhythmic paradox.
No, let me guess. Flecainide causes the very thing it's supposed to prevent.
Unfortunately, yes.
Yeah.
Recent data cast serious heavy doubts on the safety of class IC drugs.
Really?
Yeah. They are notorious for aggravating pre-existing arrhythmias or even inducing new life-threatening ventricular tachycardias that basically resist all treatment.
Wow.
Because of that severe toxicity, they are really reserved only for the most refractory, stubborn cases where absolutely nothing else works.
So if you've just survived a heart attack, your heart muscle is bruised, scarred, and highly susceptible to those short-circuit reentry loops. Your doctor wants to protect you, but they obviously don't want to risk a potent sodium blocker like flecainide making things worse.
Exactly.
So this is where we shift away from sodium entirely. We move to class 2 and class 4 drugs. These agents focus on entirely different parts of the cellular cycle, stepping away from that explosive phase 0 spark and focusing more on dampening the overall system.
Correct. Let's start with class 2, which are the beta blockers. Drugs like propranolol and metoprolol. These agents diminish what's called phase 4 depolarization.
And phase 4 is that resting phase, right?
Yes.
It's the period between heartbeats where those latent pacemaker cells are slowly creeping back toward their firing threshold. I picture it like a rubber band being very slowly stretched until it's ready to snap. Beta blockers depress that automaticity. They slow down the stretching of the rubber band.
And they do that by blocking the sympathetic nervous system.
The fight or flight response.
Exactly. Your sympathetic system releases adrenaline, which makes that cellular rubber band stretch and snap much faster. By blocking those adrenaline receptors, beta blockers basically tell the pacemaker cells, hey, take it easy, slow down. This decreases the heart rate and the overall force of the heart's contraction.
This is why a drug like propranolol is an absolute lifesaver, literally. It significantly reduces the mortality rate in the very first year following a heart attack.
It does.
And it does that specifically by preventing sudden arrhythmic death. It shields that fragile, healing heart muscle from surges of adrenaline that could spark an electrical chaos.
It acts as a chemical shield. And clinically, a drug like metoprolol is often preferred over propranolol.
How is that?
Well, propranolol blocks beta receptors indiscriminately, including the ones in your lungs, which can cause bronchospasm, essentially triggering asthma-like symptoms.
Oh, yikes.
Yeah. Metoprolol is much more selective for the heart, making it a safer bet for a wider range of patients.
Okay, so that's class 2. Now, alongside the beta blockers, we have class 4, which are the calcium channel blockers. The main players here are verapamil and diltiazem.
Right.
If sodium is the spark that starts the contraction, calcium has to be the fuel that sustains it, particularly through the AV node. The AV node is that crucial electrical gateway between the upper and lower chambers of the heart.
Yes, exactly.
So by blocking calcium, you're essentially putting a strict speed limit on that gateway.
You really are. You're decreasing the inward calcium current, which slows down the conduction velocity through the AV node. And this brings us right back to our orchestra analogy.
Okay.
Remember the reentry loop? The violin's stuck on repeat because of a unidirectional block.
Right. The electrical impulse hits a dead end, travels down the normal path, but then sneaks backward up the damaged path to create a spinning infinite loop.
Well, drugs that slow conduction also inherently prolong the refractory period. That's the time a cell needs to reset before it can physically fire again.
Makes sense.
If you slow the conduction down enough with a calcium blocker, you prolong that refractory period so much that you actually convert a unidirectional block into a bidirectional block.
Oh, wow. Wait, okay, I see it. It's like if a car is stuck speeding backward around a roundabout and you just drop a massive concrete barrier at both the entrance and the exit.
Exactly. If the impulse is spinning in a circle and you suddenly block the path in both directions, the loop hits a brick wall. The reentry circuit is broken. The rogue section of the orchestra is silenced, allowing the SA node, the normal conductor, to finally take over again and restore a normal sinus rhythm.
That is, I mean, it really is pure electrical engineering. You are quite literally patching faulty wiring by manipulating the chemical speed limits of the current.
You are.
But obviously, the heart is endlessly complex, and sometimes just dampening the AV node with calcium or beta blockers isn't enough. Sometimes the wiring is so profoundly erratic that you need something that alters the fundamental reset time of the cells themselves.
You need the heavy hitters.
Which brings us to class 3. The potassium channel blockers. These are arguably the most potent and complex drugs we have.
They are. Class 3 agents block the outward flow of potassium during repolarization.
So if sodium rushes in to start the beat, potassium has to flow out to reset the cell for the next beat.
Precisely. By blocking that outward flow of potassium, you are significantly prolonging the duration of the action potential and the effective refractory period.
Okay.
You're basically stretching out the time it takes for the heart cells to reset.
And the poster child for class 3 is a drug called amiodarone. The story of this drug is just wild to me.
It's quite a story.
It's incredibly effective. It's essentially the mainstay heavy artillery therapy for severe refractory arrhythmias that nothing else can touch. But its pharmacological profile is just a total mess.
It is wildly complex. Even though it's officially classified as a class 3 potassium blocker, it actually shows actions from all 4 classes.
Wait, really? All 4?
Yeah. It blocks sodium, it has beta blocking activity, it blocks potassium, and it blocks calcium. It is a true broad-spectrum antiarrhythmic.
But the side effects, I mean, this is where the cure really borders on being as dangerous as the disease. Amiodarone's molecular structure contains iodine. In fact, it's structurally very similar to thyroxine, which is your natural thyroid hormone.
Right.
Because it looks so much like a thyroid hormone, it can completely disrupt your endocrine system, causing severe hypothyroidism.
And the toxicity doesn't stop there. Amiodarone is highly lipophilic, meaning it loves fat.
Okay.
It distributes extensively into your body's adipose tissue. Because it just sits there in your fat cells, it has a half-life of several weeks.
Weeks?
Weeks. Even after a patient stops taking the pill entirely, the drug continues to circulate in their system for a very, very long time.
And while it's circulating, it's wreaking havoc. It can cause pulmonary fibrosis, which is a lethal scarring of the lung tissue. It causes liver toxicity. It causes neuropathy.
Heavy toll on the body.
And perhaps the most visually shocking side effect, because of that heavy iodine accumulation in the skin, combined with sun exposure, it can literally cause irreversible blue skin discoloration.
Yes, the Smurf effect.
You take a pill to stop your heart from short-circuiting, and you turn a literal shade of blue. It's crazy.
It perfectly highlights the extreme, almost medieval trade-offs we still face in modern pharmacology. Now, researchers recognized how toxic amiodarone was, so they tried to engineer a safer alternative.
Okay, what did they do?
They developed a derivative called drondarone. They essentially took the amiodarone molecule and stripped away the iodine moieties, hoping to protect the thyroid and lessen the overall toxicity.
A noble effort, but it failed, didn't it?
Completely. And clinical trials revealed that without that specific molecular structure, drondarone was significantly less effective than amiodarone at actually preventing the recurrence of lethal arrhythmias.
So you are literally forced to choose between a drug that works brilliantly but might destroy your lungs, ruin your thyroid, and turn you blue. Or, a safer drug that might just let you die of an arrhythmia.
It's a brutal choice.
And that's not even touching on the most dangerous side effect of class 3 drugs as a whole, which is QT prolongation.
Right. Because these potassium blockers widen the action potential and delay the reset of the cell, they prolong what's called the QT interval on an electrocardiogram.
And why is that bad?
Well, this elongated reset period leaves the heart incredibly vulnerable to developing a specific, highly lethal ventricular arrhythmia called torsades de pointe.
Torsade de pointe. It translates from French to twisting of the points.
Exactly.
Which is exactly what it looks like on an ECG paper script. The waveform literally looks like a party streamer twisting around a central axis. It is terrifying to look at and incredibly deadly. And it's not just amiodarone that does this. Quinidine is notorious for it, too.
Yes, quinidine.
Yeah.
It's technically a class IA sodium blocker, but it has strong class 3 potassium blocking activity as well.
And quinidine has its own bizarre toxicity profile called synchonism. Quinidine is an alkaloid originally derived from the bark of the cinchona tree, just like the antimalarial drug quinine.
Right.
Because of its alkaloid nature, it crosses the blood-brain barrier and interferes with the central nervous system, specifically the cranial nerves.
Yeah, the symptoms are pretty severe.
Patients experience blurred vision, severe tinnitus, which is a constant ringing in the ears, headaches, dizziness, and even psychosis. You're taking a heart medication, and suddenly you're hearing high-pitched ringing and hallucinating.
The toxic potential of all these drugs is exactly why their clinical use is weighed so incredibly carefully. Every single prescription is a tightrope walk between suppressing the bad rhythm and triggering a new devastating systemic reaction.
Which honestly makes the final drug we need to discuss feel like an absolute miracle.
It really is unique.
It sits completely alone in the other category, adenosine.
Adenosine is fascinating because unlike these complex synthetic alkaloids or iodine-heavy compounds, adenosine is a naturally occurring nucleoside. It's already in every cell of your body.
And it does one specific job better than anything else on Earth. It is the absolute drug of choice for abolishing acute supraventricular tachycardia.
Yes.
If a patient is lying in the ER and their heart is racing at 200 beats per minute because of a short circuit up above the ventricles, the doctor will push intravenous adenosine. But the wildest part is how fast it works and how fast it vanishes.
Its duration of action is approximately 15 seconds.
15 seconds. The moment it hits the bloodstream, it is rapidly taken up by red blood cells. But in those few seconds it's active, it severely depresses conduction through the AV node. It literally flatlines the heart for a brief, terrifying second. A total hard reset.
It clears the electrical cache.
Wow.
It forces the AB node to completely stop, breaking the chaotic reentry loop instantly and allowing the SA node to wake up and take over again.
And because it vanishes into the red blood cells so quickly, it has almost zero long-term toxicity.
Exactly. The patient might feel a sudden, intense flushing, chest pain, and a drop in blood pressure, but 15 seconds later, the drug is functionally gone.
I cannot get over the sheer extremes of this medical field. On one hand, you have amiodarone, which burrows into your fat tissue for weeks, destroys your lungs, and turns your skin blue. And on the other hand, you have adenosine, which does its incredibly dramatic job of flatlining the heart, and then completely vanishes in the time it takes to tie your shoe.
It's a huge spectrum.
The spectrum of how we can chemically manipulate this internal power plant is just staggering.
It really is a delicate, almost precarious balancing act. Doctors are functioning as high-stakes electrical engineers.
They really are.
They're deploying highly specific channel blockers, targeting sodium, potassium, and calcium to patch faulty wiring, to alter chemical speed limits, and to construct bidirectional roadblocks to shatter those reentry loops.
But they are doing all of this while constantly looking over their shoulder at the proarrhythmic risk. The ever-present threat that fixing one short circuit might just accidentally cause a fatal new one?
Exactly. It requires a profound, intimate understanding of not just what these drugs do, but why they do it at a microscopic cellular level, and how that specific molecular blockade interacts with the patient's unique electrical grid.
So what does this all mean for you listening right now? If you take nothing else away from this deep dive, I hope you leave with a profound appreciation for how beautifully intricate your own heartbeat is.
It's a miracle of biology.
Every single lub-dub you feel is this fragile, automatic symphony relying on absolute perfect chemical timing. Sodium rushing in to spark the fire, calcium flowing through to sustain the squeeze, potassium flooding out to reset the system. It is an electrochemical miracle happening billions of times over the course of your life.
And when that timing falters, the pharmacological tools we have engineered to fix it are undeniably powerful, but they're also deeply, fundamentally flawed.
Which actually leads me to a final thought I want to leave you with. There is a small, almost throwaway clinical note in our sources that has really stuck with me. We've spent this entire time talking about the sheer power of these drugs, but also their terrifying dangers. The full-body toxicities of amiodarone, the lethal proarrhythmic risks of flecainide,
Right.
the deeply unsettling paradox that the very medicine used to treat irregular heartbeats can cause irregular heartbeats.
The proarrhythmic paradox. It's the inescapable shadow of cardiac pharmacology.
Right. And because of that paradox, because these chemicals are so volatile, implantable cardioverter defibrillators, ICDs, are becoming incredibly widely used.
That's very true.
These are tiny, sophisticated microcomputers surgically implanted right into the chest. They constantly monitor the heart's rhythm 24/7, and if they detect a lethal short circuit like ventricular tachycardia, they instantly, automatically shock the heart back into a normal rhythm.
No heavy metal toxins, no iodine building up in your skin.
Exactly. No guessing how a sodium blocker will affect a damaged ventricle. So I leave you to ponder this. Given the incredible toxicity and the constant chemical tightrope walk of these antiarrhythmic drugs, are we fast approaching an era where we simply abandon chemical pharmacology altogether to fix the heart's electrical grid?
It's a really interesting point.
Will we look back on things like amiodarone as medieval and instead rely entirely on implantable hardware to manage our rhythm?
It's a highly compelling question. When the chemical tools are this dangerous, an automated hardware solution might not just be an alternative. It might just be the inevitable future of the electrical grid.
Definitely something to think about the next time you feel your heart skip a beat. Thanks for joining us on this deep dive.